Thank you all for coming. My name is Dan. I'm a data engineer here at Skylight, and we have a little presentation today about some work that we've done in partnership with the CDC, USDS, that's the U.S. Digital Service, um, and Virginia Department of Health. So just before we get too far into the weeds, we're hoping that as a result of being here today, you'll learn that there are some really great open source, freely available tools that should be able to really help state and other local public health departments um, do a better job handling their data. We've been working on this project for more than a year now, and we're excited to sort of share some of the learnings with you and also share, and I guess also just sort of raise awareness of some of the work that's going on out there. So before we get into more of the specifics, just a brief overview or introduction of who we are as Skylight. We're a relatively small digital consultancy. We work with other government agencies to help them basically do a better job at offering whatever services they offer. We have people part of the company who have been working at sort of all levels of civic tech. And also we have a lot of people now working in Skylight who also have a lot of very intimate experience working with healthcare data. We've done this work for the last several years with a variety of government agencies at the federal level, and also some work at the state level. Sort of a brief overview on how we work. We really care about building technology and solutions and tools that are for our clients and our users. We're not about coming in with a canned solution, sort of a one-size-fits-all approach. We're much more interested in taking the time to get to know people and take a careful approach in building relationships and doing user research so that we can make sure that we're building technology that really works for people. And I'm sorry, at the beginning of the talk, I should have mentioned before I joined Skylight, I worked for Maine's Public Health Department, the state of Maine's Public Health Department for a while. So I'm also have some familiarity of what it's like to work in a state or local public health department. In terms of the work that we've already done, we've been really highly involved with a lot of the recent work that the CDC has been doing towards data modernization. Sort of right at the forefront, a lot of perhaps one of the silver linings of the pandemic is that we've kind of had the opportunity to refocus on the need to improve our approaches to sort of the whole public health tech stack. And we've been really involved with that work. Some of you may be familiar with Simple Report. That's a project that's a partnership between the CDC and the U.S. Digital Service, and it's primarily Skylight engineers who are the folks behind the scenes and researchers and designers who are actually making that piece of technology work. Additionally, this is getting to the work that I do on a day-to-day basis. We, as part of the Public Health Data Infrastructure Project, which we'll talk about in a minute, are doing work actually building some of the initial building blocks that are part of the CDC's North Star architecture vision. And we've also started putting together these building blocks into starter kits. We're part of the CDC's FHIR community of practice. Okay, so I mentioned public health data infrastructure before, which is the project that I work on. And so if for those of you who are familiar with Simple Report or other reporting tools, they only kind of take care of half of the equation, right? A tool like Simple Report helps data get to a public health department. But then, as all of you are quite aware, right, it's not nearly sufficient to just receive an HL7 message. you need to actually be able to do whatever the work is that you need to with that data to actually do the public health. So the problem that the public health data infrastructure project is trying to address is that once data arrives at a public health department's doorstep, they need to be able to work with that data, and there are numerous challenges in doing so. The way we're hoping to solve for that is by building a sort of a large toolbox of open source, freely available modular tools that the CDC has this acronym STILT, state, territorial, and local and tribal public health departments. So if I refer to STILTs during the course of the talk, that's what I'm referring to. But the goal is that we're putting together this toolbox of these modular tools that STILTs can pick and choose from to compose pipelines that address hopefully any of their public health data related challenges. Some examples of some of these building blocks that we've already built. We have a building block for doing FHIR conversion from HL7v2 or CCD to FHIR. We have another building block that focuses on geocoding. And then another building block that's currently in development is tabulating FHIR data based on a user provided schema. And we'll talk more about that later today. Okay, so one of the early stages of the PHDI project was a partnership with Virginia Department of Health. And so working closely with Virginia DOH, they asked us to build a cloud-based system that could ingest ELR, VXU, ECR data to support. We had sort of these two use cases we were considering. The first was doing validation of ECR data, and the other was doing COVID breakthrough analysis. And so for those of you who are familiar with ELR, VXU, and ECR, you'll know that ELR and VXU are HL7 messages, HL7v2 messages, and ECR are CCD documents, which is really sort of additional specifications built on top of XML. So we have, in terms of the data we had to work with for this project, we had two different types of HL7v2 messages, and then another very different data format, CCD, to work with. And then if we look at sort of the use cases that we needed to consider, both ECR validation and COVID breakthrough analysis, both of those require that we can integrate data across all of those three streams. For instance, doing COVID breakthrough analysis requires that we're at least able to look through positive ELRs, identify which ones meet a case definition, and then also see if any of those patients in those cases were vaccinated at whenever their illness began. So keeping these two things in mind is what motivated a lot of our architectural design decisions. One, needing to work with a variety of different types of data, and two, needing to integrate all of them into one single source of truth to be able to do ECR validation and COVID breakthrough analysis. So this is an architecture diagram of what we ended up building for Virginia as a result of this partnership. We're going to spend basically the bulk of the talk talking in detail about each of the steps, but to provide a brief high-level overview, if we start in the top left corner here, we receive raw data or source data. There are a variety of ways that data could be put into a cloud environment. Primarily for this, we worked via an SFTP server that Virginia DOH made available to us. Then that source data is moved into a cloud storage bucket. One important piece of our architecture is that this whole pipeline is event-driven. So there are no bulk ETL processes that run on some rigid schedule. Basically, as soon as data is uploaded, that event kicks off the ingestion pipeline. So when data is uploaded, this validation building block is one area of active development. It doesn't currently exist. This is sort of, this architecture diagram is it's a more advanced iteration of where we were when we ended with Virginia. So the validation piece is coming soon, but as soon as raw data is added to cloud storage, we kick off our ingestion process. The first part of that is converting to FHIR. We'll talk more about the FHIR conversion in a moment, but there are a bunch of good reasons that we convert to FHIR, but the primary one is conversion to FHIR is our mechanism for being able to integrate across all 3 different data streams that we're working with, because we can convert our 2 different HL7v2 message types, ELR and VXU to FHIR, and also our ECR data to FHIR. And so then after that conversion, we're able to work with all of the data in the same way, so we can treat it consistently and in a standard way for the rest of the pipeline after that initial conversion step. So it means that we're not building bespoke ingestion processes per reporter or per data type. The conversion to FHIR is what allows us to do that. There are also a lot of other benefits to working with FHIR. But after we convert to FHIR, then we do some standardizations. These are things like standardizing patient name, standardizing phone number. Then we move on and we geocode patient address. We can standardize the address, fill in zip code if it's missing, and then also enrich the data with latitude and longitude to support downstream spatial analytics. And then we have a record linkage process, which we'll talk about in a little bit more detail in a bit. After that, data is loaded into the FHIR server. And for those of you who aren't familiar, there's FHIR, which is another data format similar to HL7v2, or I should say it's data format. And in that regard, they're similar, but it's actually, the format itself is very different. And then a FHIR server is really a combination of 2 pieces of technology. There is some kind of database or some way to persist the data. And then there is a standard FHIR API that sits on top of that database. And what's really valuable about the FHIR API is that it's a standard. So you can go to, in theory, any FHIR server anywhere, and the way you communicate with that FHIR server, the way you upload data, get data out, update records, all those processes are the same. And so it makes it sort of having the FHIR server at the core of this architecture, setting ourselves up for future interoperability and data exchange. So that covers basically the ingestion portion of our architecture. That's how we receive raw data, convert to FHIR, do some standardizations and enrichments, clean the data up, and put it into the FHIR server. But that's great in some ways, but it doesn't do us a whole lot of good unless we can actually get the data back out to do public health with it, do the analysis and the reporting that all of you need to do on a daily basis. So that's sort of the second half of the FHIR server, or oftentimes we talk about ingestions to the left side of the FHIR server, and then our extraction processes on the right side of the FHIR server. But we have additionally developed 3 additional building blocks to extract, tabulate, and load data from the FHIR server, given a user-defined schema. So this is actually an interesting example of how this building block approach that the CDC is working on ends up being very, very flexible, because the way we're actually making this functionality available to users is actually by bundling up the extract, tabulate, and load building blocks into a single service that just does tabulation. So what I mean by that is we're working on developing a single service that a user can provide a schema to, so they just say what data they want. We figure out how to get the data out of the FHIR server, and then we let the user persist that data in tabular form in any of a wide variety of formats. So that's the brief overview of what we've built, sort of the architecture that PHDI is working on. I know it was a lot, but we'll talk through each of the steps in much more detail now. Jump too far ahead. So first, we're going to focus on just the left side of our architecture and the ingestion pipeline. And the real takeaways that we're hoping you can get from this part of the talk is that We convert the data to FHIR, and so we're after the conversion step, we're just working with FHIR, and then we have FHIR data to work with. And additionally, the ingestion process cleans and enriches data. So we're moving a lot of the data cleaning and manual manipulation that has to be done now frequently at the point of analysis. We're moving all those far upstream so that we can have a single source of truth with clean data that supports analytical use cases downstream. Okay, so the first step in the pipeline, as I mentioned before, is doing the conversion to FHIR. And for the purpose of this example, we have sort of on the left, notionally representative HL7 data. This is a horrendous simplification of what that format actually is. For those of you who have gotten into the weeds with HL7v2 data, what we have on the left is really an incredibly simplified version of a PID segment, the segment of an HL7v2 message that contains patient demographics. And then on the right, we have, again, a notionally correct example of what the resulting FHIR data would look like from doing this conversion. Part of the challenge here is that HL7v2, by nature of its format, has exceptionally long rows, which makes it hard to fit on a slide, and FHIR, by virtue of its format, has a lot of rows, so it gets vertically very long. So we've done this simplification just for the purpose of working through the example. So the first step is we do this conversion to FHIR. We could probably spend a whole 1 hour talk talking about the process of doing the FHIR conversion. But if there are questions about how we do it, I'm happy to talk about that at the end. The next step is that we standardize patient name. And so you'll notice in this example, on the left side, we have a Jane Doe whose name is not only reported in mixed case, but also for some reason, maybe somebody made a typo, has a non-alpha character, a 3, incorporated in it. So our name standardization process will remove leading and trailing spaces. It removes non-alpha characters, and you can see on the right, we also shift everything to uppercase because it makes it easier to do patient matching when everything is consistent like this. I should note the name standardization building block that we've built has options for users to configure the output. So if you would prefer not to use all uppercase, you'd like things to be lowercase, if you would like to remove leading and trailing spaces, or if you would prefer to leave those in, there are opportunities for a user to specify non-default behavior. So it's a little bit flexible in that way. Additionally, because of this sort of modular building blocks approach, if you don't like the way this name standardization process works, you can write your own. So the next step in our process, another one of our standardizations, is standardizing phone number. If you notice on the left, we have, this is a non-standard phone number representation. It's got parentheses, dashes, there's an extra space in it. Additionally, it's not in an international format. So our phone number standardization standardizes phone numbers into the ISO E.164 standard, which effectively means we don't include any punctuation or spaces in the number, so it's just the digits, and then we include a plus sign and whatever the country code is. This is an American phone number, so we have a +1 to begin this phone number with. We figure out what the patient's country should be based on their address. The next step in our pipeline is that we do some geocoding. So you can see on the left, we have a messy address that's missing a postal code. The abbreviation for AV is misspelled. We also don't have any latitude and longitude. So we do our geocoding. We're able to clean up the address. We're able to find the postal code and incorporate latitude and longitude for future use. Currently, we support the Smarty geocoding service as well as the US Census API. Likely in the future, we're going to also be developing support for both the Esri geocoding service and Google's geocoder. The final step in our pipeline right now is our approach to record linkage. And this is the process of looking at different lab results or vaccination records, different reports to a public health department, and identifying that those different records are actually of the same patient. Some people refer to this as patient deduplication, but it's basically the process of identifying that a whole set of records all go to the same patient even though they were reported separately. So what we're currently doing, although it's a fairly rudimentary approach, and doing something more sophisticated is right now an area of active development. What we do is we take the patient's standardized name, standardized address, and date of birth, and we compute this hash based on them. Effectively, we take all of the characters in the name, date of birth, and address, do some fancy math on it to get this hash, and then we can use this hash to link other patients. Effectively, it's just a slightly more complicated way to just match patients directly on name, date of birth, and address. So any patients that have the same name, date of birth, and address will have the same hash. What's kind of cool about using this hash is that it is not computationally possible in the lifetime of the universe to reverse out the actual identifying data that went into it. So we can include the hash safely in a de-identified data set so that you can link de-identified records that go to the same patient without actually including any of that patient's identifiers. So after that, we need to upload to the FHIR server, but we'll talk about that in a little bit. So the upshots from this approach to the ingestion pipeline is that we're able to very far upstream before we run into any specific analytical or reporting use cases. We're able to improve data quality. We're able to improve data consistency, and both of these are because we do all these standardizations and the enrichment with geocoding and record linkage ahead of time. And then also we'll talk about how doing a better job record linkage supports work that's being done to address health equity. So just to go through some of the results of this work, just based on our very rudimentary approach to record linkage or patient deduplication. So again, just matching patients on name, date of birth, and address. We were able to see fairly significant reductions in the total number of patients. So this was encouraging. And additionally, because again, we'd converted everything to FHIR, we're able to do record linkage across all three data streams. So we can figure out, which immunizations go with which lab report, and which lab report, matches up with the ECR that was generated as a result of a positive lab, for instance. So we're able to do record linkage on the combined data set. And so we're relatively pleased with these results. And so we'll talk a little bit more about that, but to touch on how doing a better job on record linkage can help make sure that a public health department has better data to think about things like health equity and understand where the disparities are, and then be able to hopefully tailor policy to address them. An important sort of effect that falls out of doing a good job at record linkage or patient deduplication is what we've been referring to as demographic data recovery. We have some of our results from this small pilot on the left, but as an example of how this process works on the right, again, this is sort of our, just sort of like suggestion of what HL7 data, V2 data looks like. On the right, we have two different records for a Jane Doe. The second one is missing their race and ethnicity. We also have two records for a John Doe. One record is missing John's race, and the other is missing John's gender. Now, so in the top segment here, 25% of our patients are missing gender, 50% are missing race, and 25% of them are missing ethnicity. If we're able to have a robust record linkage process or patient deduplication process that allows us to confidently say that these two John Doe, the John Does referred to in these two different records are actually the same person. And similarly, the Jane Doe referred to in these two records are actually the same person. We can condense all of this data down into just the two records that we have on the bottom, one for a Jane Doe and one for a John Doe, that have complete demographic data. We have race, ethnicity, and gender for all of them. Obviously, a 50% reduction in records missing race is truly exceptional, but for the purpose of this example is just to demonstrate how this is an effect that falls out of doing a good job with record linkage. So by doing a good job with record linkage, we can have a greater proportion of records that have complete demographic data, which should in turn help efforts to understand and address health equity disparities. Working with this data, we were able to see a fairly modest 2 to 3% decrease in ELR reports that were missing race and ethnicity. We unfortunately didn't really see this effect in the ECR and VXU data that we worked with. There are a couple caveats in this analysis. We only had a fairly small amount of data, only from an 18-day window that we were working with. And there was also about 4 times more ELR data that we received from Virginia than ECR and VXU. So there was just, the bulk of the data we had was from a small range time window, and it was mostly ELR. So basically, the way we've been thinking about these results is that given our fairly rudimentary approach to record linkage and the small amount of data we had, we're really encouraged. And we think that with a more robust approach to record linkage and also with more data from larger time periods, which would be representative of what a public health department is working with in practice, that this could be a very fruitful approach to using the data itself to clean the data and enrich the data. Okay, so in the first part, we talked about the ingestion pipeline, so how we receive raw data, process it, and get it into the FHIR server. But like I mentioned before, we fully understand the data doesn't really do any of you much good if it's just sitting in the FHIR server and you have no way to get it out. So what we're going to talk about now is the process that we've developed for how to get data back out of a FHIR server. And so the first step in doing this is to figure out what the data is that you want, to define your schema. And so this is basically deciding that for a given reporting or analytical use case, you need a table or a set of tables that have, whatever the columns in them that you require for that specific use case. This is an example of a schema that we developed, just an example of a potential schema for doing some initial ECR validation that came out of our work with Virginia, but we have a patient table, we have another table that holds condition values. And so it's so valuable about our approach for getting the data out of the FHIR server is that all you need to do is just define your schema, just state what data is, what data you would like. You don't need to worry about how to actually get the data out of the FHIR server. And the reason for that is that we figure out, based on the schema that's provided to the tabulation service, we figure out what API calls need to be made to the FHIR server. So as an example of what's actually happening under the hood, let's say we just wanted that patient table, the big table in the middle of the schema on the previous slide, and we only wanted to include patient name, gender, and date of birth in it. Up here, we have an example of what the query is that we'd actually send to a FHIR server. So we'd have the URL where a FHIR server lives, and then all of this mess under the blue brace here is how we tell the FHIR server, hey, I'd like all the patient records and please include name, gender, and date of birth. This is, while the FHIR API is incredibly powerful and robust, it definitely requires a fair amount of familiarity with the documentation and how to use it, which is actually why we've included this as an example. So our tooling does, what I think is so valuable about it is that users don't need to understand basically anything about the FHIR API. Users can just provide the schema, something like what I showed in the previous slide, to our tabulation service, and we read through the schema and figure out what API calls need to be made to the FHIR server so that we can get data back out that looks like this example response on the right here. But additionally, we don't just stop there, because getting this whole mess of JSON is also not terribly useful for analytics. So the next step of the tabulation process is that, again, based on the schema that a user provided, we read through the response from the FHIR server and populate all the rows in the tables that the schema specifies. So you can see here we got a response that contains 2 patient records, and going from the column on the left here to step 1, we take care of parsing out all the values and sticking them into the correct rows and columns in the table. The final step of the tabulation service, is that the user is able to specify how they would like the data to be persisted or stored. Currently, we support writing to CSV, Parquet, and SQLite, an SQLite database. Eventually, there are a whole bunch of reasons why any of those data formats might be valuable. Eventually, the long-term development plan is to basically offer direct connections to existing databases so that this data wouldn't even be persisted as a file someplace. It would just be written directly to potentially a production database. But the user gets to choose not only what data they need, but also how the service provides the data back to them so that they can pull it into whatever their favorite analytics or reporting tool is and go about doing the public health business. So in terms of the results or the value of this sort of extraction process is that it's a very flexible way to access data from a single source of truth. It doesn't require a lot of technological, or I should say, it doesn't require familiarity with certain database technologies or APIs, and it's very adaptable and flexible because it's easy to update the schema that are provided to the service. One of the things that we learned a lot from talking with folks in Virginia is that the current system is very fixed, and so they have reports that are generated on some schedule, but when times change during COVID and all of a sudden those reports need to be modified, new fields need to be added, a new table is required for a data mart. It was really challenging for them to figure out how to make those changes. And so because we just keep all of the data after it's been cleaned in a generic FHIR format, and then allow schemas to be applied when data is queried or requested from the FHIR server, it's incredibly easy to just specify whatever data you'd like and get that back. If things need to change in a week, or if you have a new use case, you just write a new schema or modify an existing one, and you can get your data back. There's no need to go through talking with a database administrator, or talking with the one person in the department who's familiar enough with Rhapsody to make an adjustment to NBS, or whatever it is. That's why we think this is such an improvement. Basically, our goal with this tool is to just put the data directly into epidemiologists and analysts' hands to let them do what they've been trained to do and what they're passionate about, and not have to be constantly fighting whatever the IT tools are that their public health department has. So again, you can get the data out of the FHIR server. It doesn't require in-depth familiarity with FHIR, HL7v2, CCD, or any of the underlying database technologies or APIs. We're also working on a nice schema generator, so an application that has a graphic user interface that makes it very easy to just basically click on which fields you would like included in your schema, and to generate your schema that way, not even have to write the configuration file yourself. So just sort of thinking about the benefits that Virginia was able to see based on their existing system versus what we built for them. I mentioned before the entire architecture that we built is event triggered. So the experience I had working in Maine is that there were several sort of large bulk ETL processes that ran on a schedule. Some were daily. There was another we had that was hourly. Um, and because of the volume of data that we were receiving in Maine during the pandemic, sometimes those ETLs wouldn't finish, and then their partial completion would have other downstream effects. And Virginia had a similar system where they had a very rigid task scheduler for all the different ETL processes to occur on. Um, but basically, instead of waiting and saving up a whole lot of data processing to happen on a schedule, our event-triggered approach just allows the system to, gradually process data continually as the data is received. Um, Also, because everything is cloud-based, all of the infrastructure is highly available 24/7. It also has baked-in scaling so that if there's a surge in the amount of data that's received, the infrastructure is able to scale out horizontally to process that large influx of data, and then it scales back down so that you're not consuming additional cloud resources that are actually necessary. The entire process that we developed is automated. There's virtually no manual input required. Our architecture is also significantly faster. We're able to handle about 20,000 HL7 messages per hour. And that's before we did any real performance tuning. This was such an improvement over what Virginia had going out of the box that we didn't even really look at ways to make it be any faster. But there's certainly potential to increase performance further. Additionally, because of all the sort of baked-in monitoring and logging that just sort of comes for free by using cloud services, there's much greater visibility into this architecture. So where are things going from here? Well, all of the functionality that we've written, all of our building block source code is written in Python, and it's available as a PyPy package. You can pip install PHDI today. It's also available on a CDC GitHub repository. Additionally, if any of you are familiar with containers or Docker, our FHIR converter is containerized, so it can be run basically anywhere you can run a container. And similarly for our ingestion service that handles the standardization and geocoding and record linkers that we talked about. We also know that actually deploying these building blocks to the cloud is a significant hurdle. So we've been building these starter kit repositories that are basically we orchestrate the architecture that we presented here today. We have all the infrastructure as code for it packaged in repositories that support GCP and Azure currently. AWS is coming soon. And we've also got a link to our website. We'll make the slide deck available at the end if anybody would like these links. In terms of things that are coming soon, starter kit support for AWS, as well as finalizing our tabulation surface is coming. Currently, we are working on figuring out how to have a robust validation process for both HL7 and ECR data. And we're also looking at more sophisticated approaches to record linkage. If you'd like help with your data modernization, if using some of these open source tools seems interesting, or if you'd like to take a different approach, we'd be happy to have a conversation with you about that. We're happy to be flexible in how we do that work. We are on GSA Mass. And that's what we had for the day. Does anybody have any questions?